sometimes if you're too gung-ho, you don't. It's because you haven't contemplated the downsides of having surgery, and there's always a downside to anything you do. Just whether it's taking a medication or having surgery, there's complications that can happen. There's secondary things that can happen.
Well, today I'm joined by Dr. Tom Degan, orthopedic surgeon of almost 45 years, correct?
Correct.
Okay. And now you're semi-retired?
Pretty much retired, yes.
Pretty much retired.
Doing a little medical legal work, and I've got a son who followed my footsteps, so we talk a lot of shop as well.
So you're busy in retirement, though. How did you have time to be an orthopedic surgeon?
Boy, yeah, you look back at the working years and see what you accomplished, and either you were younger and had more energy, or you managed time better, or there are a lot of things that just didn't happen because you make sacrifices. Everybody does for work. They've put off things that they would like to do, or things that need to get done because of kids and family and job requirements and such. So but everybody seems to stay busy in retirement because there's a lot of things that didn't happen that still need to happen, and so it's been busy, and having the little work I do keeps me busy, and my wife she's a nurse practitioner. Was a therapist prior to that, occupational therapist, so she's also intellectually engaged, and she's gotten into more functional medicine sorts of things, so we've explored that, and there's always ways to keep busy and keep stimulated if you want to.
Mm-hmm. So how did you get into orthopedic medicine? What was your, where did you go to school, and how did you make the decision to go the orthopedic route?
Well, I decided, I guess, to go into medicine or be a doctor probably in about 5th, 6th grade. A friend and I each decided to do that. He was a cardiologist in New York, wound up, and I wound up going into orthopedics. But I had no particular desire for any specialty until I was in medical school. As I said, my wife was an occupational therapist, so she interacted with orthopedics and physiatry and that quite a bit. And she thought I would like it, and she's wise, and she was right. It was a good fit for me in terms of the intellectual stimulation, but also the hands-on, actually doing things, and it's a lot more, at least it was a lot more concrete in terms of what you were doing than some of the more esoteric medical specialties and subspecialties. It was a hands-on, doing things sort of profession, and it combined both non-surgical and surgical things, and that was appealing to me, and it also is a specialty where, at least during my time, you interacted quite a bit with patients, and the interpersonal interactions was a big draw to me. I would not do well, probably. More of a people person would not do well sitting in a little lab or someplace cloistered away.
Is that one of the biggest things that's changed over the past 40 years? How much,
It is changing in terms of the interaction you have with the patients, in that a lot of the non-surgical things tend to be handled by physician's assistants now. And they were just getting started at the end of my career, so most of my career didn't have assistants or the intermediaries. It was just you and the patient, and so it wasn't as efficient products in terms of production and output. If you consider surgical cases and the amount of billing you're able to generate, it was not efficient that way, but there was more of an interpersonal interaction with the patients. You knew the patients better, and that has, I think, changed. There's pretty much everybody has an assistant, and they are the first interaction. If you call the office, you wind up typically speaking with the physician's assistant, not the physician. So that has changed, especially in probably the last 15, 20 years.
Mm-hmm. So the nurse practitioners, PAs, are the ones who are doing a lot of the front end, even consultations and follow up, and the surgeon is more like just coming in and doing the procedure.
Yes, I think there's a lot more of that. Yeah, you can tailor that to some degree in terms of what you want for your practice, but the tertiary centers tend to be structured that way. I think it's probably less so as you get into smaller practices, smaller venues, but certainly in the university setting or a large clinical setting, the physician's assistants tend to do a lot of the work. And the nurse practitioners are getting more and more independent and doing more of a primary type practice, I think, for the most part, although there's some that are doing a lot of surgical assisting and that sort of thing. They're tailoring their own practices now, and that is certainly, nurse practitioners were not on the radar at all when I started, and that's something that has evolved over my time as well. So it's a little more segmented in terms of, I think, what most physicians interact with their patients. That's one thing that's changed. I'm not sure it's the better. It's certainly more efficient from a business standpoint, and in terms of gaining experience. If you're spending more of your time doing procedures, you probably are becoming more familiar with the various procedures. But like everything, you gain something, you lose something.
Mm-hmm. I think patients sometimes want to see the doctor, though, don't they?
I think a lot of people do, yes.
Yeah. Thank you for joining me on the podcast. Don't forget to subscribe and let me know in the comments who you'd like to see me have on the show next. Yeah. I feel like as talented and as skilled and as much knowledge as the PAs and nurse practitioners have, because I still work in a hospital, healthcare facility, I still hear, well, when's the doctor going to be by? They want to have, understandably they're cutting you open or doing, whatever, but they still have that desire to see the physician who's actually going to be, and usually they do stop by. It's just more of an abbreviated.
It's abbreviated, and I think I'm not sure you quite have to have the interpersonal skills you needed to, 40 or 50 years ago, when you actually had to extensively deal one-on-one with people. And so you're more of you could almost say technician in some respects. Yeah, the things that are important are really not the interpersonal characteristics, and some people have to work on that more than others. Some people it's pretty natural, but that's something that is different, and I think you notice it even more as you get into more specialized settings. Some of the physicians are very good at that, and some not quite so good. And if they've got a great PA that has the personality, then everything works well. And if they don't, then they're probably more comfortable doing the technical things, whether it's doing EKGs or intervention if they're a radiologist or cardiologist, or doing surgery if they're a surgeon.
Yeah. What was it like coming out of school and doing your first like case where you're actually, I mean, I know you have like residencies and you're supervised by, another orthopedic surgeon who's kind of like in charge of everything. But what is it like that first time you actually you have to make the first incision and the first, orthopedic procedure where you're the one that's in charge? Scary or?
Well, I think you were pretty well prepared for it with your training. As a chief resident, quote unquote, you basically had, as a senior resident, your own service. And so I had a physician that was my advisor, but at that point I basically had my own clinic and scheduled my own cases, wound up generating those cases. So, and at that point, typically the attending physician wasn't in the room. So you'd done it. You were pretty comfortable doing it. Mm-hmm. It's there's always a little bit of angst when the buck does stop there. Yeah, you are the final person in the lineup, and there isn't anybody above you either for watching over you or necessarily for ready advice and that sort of thing. So there's a little more responsibility, but it's a good transition, I think, the way training works, and mm-hmm. people are competent when they come out, and I think you're better prepared to practice than you are in some other professions. I've got a son that's an attorney, and he says basically, when you get out of law school, it takes you another 5 years to become a lawyer, because you don't have the same sorts of mentorship that they do in mm-hmm. medicine.
So you talked about just some changes with like the time that you get to spend at the bedside with the patient at the beginning of your career, and kind of what if it's evolved into now. What's some of the biggest changes like in technology and innovation that like wasn't even on the radar when you started, or like that you just couldn't imagine would be in existence?
Well, in orthopedic surgery, probably the biggest things were there's sort of three areas. One are those, you think of an orthopedic surgeon, you think of broken bones and fractures and that. And I think now people think of joint replacements and that sort of thing. And those are, and then the other thing that people kind of consider with orthopedic surgery are, looking in joints, looking at knees, doing arthroscopy and all. And those three things evolved tremendously during my period of time. It seems like it's just been quantum leaps, and I think things are a little more incremental now. But for instance, they did total hips, total knees early on. They were only cemented when I started, and they'd only been doing them for 10, 15 years, and hips much more so than knees. Knees were not nearly as frequently done, and very few total shoulders. The elbows and wrists sort of started when I was in training, so that was all very early technology. Now a lot of places, the hips and knees are done with robotics, sort of laser measurement. They very individualize the prosthesis to the patient. They can do much more than they could now. So, and the fixation, now we use very little A lot of it's bony ingrowth rather than cement. So those are all completely different technologies, and the whole clinical aspect has changed. When I was first in practice, you're in the hospital for a week or 10 days after a total hip or a total knee, and my father-in-law started with cardiac surgery at the very beginning too, and people were in for a couple of weeks. A lot of times tracheotomies were done because the people were on ventilators so long, and now almost all these things in certain settings can essentially be done as an outpatient. So that's a huge change.
Yeah.
So the amount of patients you have in the hospital is much less. In terms of fractures, when I started as an intern at UCLA and at the Mayo Clinic, when we had a femur fracture, they were treated in traction and balance suspension. The old pictures you see of people in beds with their legs in a splint with ropes hanging down and all that. That was reality when I started, and very few people had internal fixation done. That had started a few years back. A lot of the Army Air Corps guys that had femur fractures came back with rods, which the Germans were putting in, which was completely new. But in the 50s and early 60s, that technology slowly changed, and there were centers across the country where that was done more frequently. Certainly Seattle was one of the early progressive areas in terms of internal fixation and doing nailings and that. I saw things as a medical student that they weren't doing in places like UCLA or Mayo even. So that was different. The attendings were not familiar with it, and I think the fracture care has come a long way. When coming from Seattle, and I had a junior resident that also came to Seattle, and when I was a chief resident, I had a nice transverse mid-shaft femur fracture, which was ideal for nailing, and none of the attendings in that had done it. And I said, well, to my junior resident, well, you were in Seattle, weren't you? You were at Harborview, you saw Hansa do it. Yeah. Well, let's just do it. So we just, read up on it and did it. And that's kind of how things start every place, is you just have interest, you have the knowledge, and you move forward. And now Mayo has a very progressive trauma program for that part of Minnesota, which they just didn't have at all back then. And arthroscopy, I had a subspecialty or certificate added qualification in sports medicine. In sports medicine, you think of scoping knees and shoulders and hips, and that's a norm in orthopedics now. When I started, I actually learned knee arthroscopy from a rheumatologist because none of the orthopedists wanted to do it. And so, some of the guys my year, we all spent time with a rheumatologist, and it was great because he was very patient, and we could see a lot, but we couldn't do much, but he got things started. And the kids that did fellowships in sports medicine after my program, none of them went to programs that had any arthroscopy. It was all, you made an incision in the knee and the shoulder, and that's what you did. And some of these guys my generation have pioneered a lot of the techniques and that. And now my son, who's doing sports medicine, is basically all arthroscopic work and very little open. So those are all huge changes. And the biologics that you hear about now, the protein-rich plasma injections and the
stem cells?
Stem cells? And
Stem
cells, protein-rich plasma, the peptides and all that. That's new in probably the last 10 to 15 years for the most part. When I was in training, it was all cortisone injections, which we've largely more and more gotten away from. They don't seem to have any long-term benefit. There's certainly some problems, but in terms of symptomatic relief, those were really game changers for people, 50 years ago. And it was a game changer for people in terms of things you could do non-surgically. So that was big during most of my career, and now I think people do fewer and fewer steroid injections. So, all that has changed significantly, and I think a lot of it is, quantum changes for the better.
Do you think that people, whether it's from the physician side or from the patient side, they can be too hesitant to go for surgery when they need it, or too pushy about getting surgery when it's not needed?
I think both can happen. There's as an example, in orthopedics, if you have a torn piece of cartilage in your knee, or a torn tendon, a rotator cuff tendon in your shoulder, if it's a partial tear or a small tear, you may not need to have anything done. If it's one that needs to be done, then it needs to be done. If you wait too long for that torn piece of meniscus, it may not be able to be repaired. The tear may progress, or you may get arthritic changes on the joint surfaces adjacent to the torn cartilage that progress. And so waiting too long means you're going to have more damage to the joint surface, and the meniscus may not be able to be repaired. Where that cartilage attaches in the front and back of the joint, the big attachments, what they call the meniscal roots, if they're torn and you don't repair it, then within a couple of months, that's usually irreparable. The whole cartilage has to come out, and arthritis ensues. So, there are times when you need to move forward and get things done, and sometimes you can wait and see how things do. But some people are too hesitant, and that may mean that a joint replacement is in their future because the meniscus in the knee couldn't be repaired. The ligament, torn ligament, couldn't be reconstructed before secondary changes came in with the knee, or the rotator cuff was torn big enough that it couldn't be repaired. So those are the hazards of waiting too long. Being too pushy, that can be a problem too. If sometimes people just don't need it, and sometimes if you're too gung-ho, you don't. It's because you haven't contemplated the downsides of having surgery, and there's always a downside to anything you do. Just whether it's taking a medication or having surgery, there's complications that can happen. There's secondary things that can happen, and so it's something that you need to consider. But just like most of us, there are people on both extremes, and you're going to see that with patients and probably with providers as well.
Mm-hmm. How did you handle the whole, the opioid epidemic? Because I know that when you first started, I don't think the opioid epidemic, it seemed like it got big in the, 90s, 2000s.
Yeah.
Were you, how did you used to control pain? And then were you more, when opioids started coming around, were you very liberal with them and then you kind of backed off them? Or how did you handle that whole opioid crisis and people getting addicted to their medications?
It didn't seem to be as big a problem, probably because the opioids, when I started, were not used as extensively, and the more potent opioids were just not available. So the
Did people just have to deal with the pain?
people would just have to deal with the pain to some degree, and you would try and keep them comfortable. But I think expectations changed. If you had a opioid that was more effective, then people might want that. And again, it's the being too aggressive. If you want to be medicated too much, you might not realize the downside. So it wasn't as big a problem when I started, and it also has become significantly more of an industry. The whole idea of pain clinics. There are a few at tertiary centers for people that had pain, but pain specialties and pain physicians and all that were just not there. When I recall having a patient that got too dependent on opioids, and I remember telling him, you're taking too many. We need to get you off them. What we're going to do is I'm going to put some Demerol and some cherry syrup, so you'll have the pain medicine, and we'll keep it at the same rate. And then, over the next 4 weeks or so, we're just going to taper you're going to same amount of cherry syrup and all, but we're going to taper down the amount, and at the end you'll be off them. And he was, and it worked great. And I didn't have, here now you would have to have agreements and contracts, and you have to have extra certifications from the government to be able to do that sort of thing. And back then it was just part of the practice and what you did, and it was fairly simple, and people seem to be much more understanding now. It's a lot more complicated, and I think there's also a tendency to maybe maintain people longer than they need to be, because that's now your specialty is pain management, and if you don't have somebody that's in pain, you don't have a patient. So, if reinforcing the fact that they have a pain issue may be, beneficial as a pain provider. It's the whole thing of cui bono, which my attorney kid is always stating you need to look at, which is, it goes back to Roman times. Cassius, who was supposedly the premier Roman judge, would always ask during the lawsuits, cui bono, who benefits? What's the backstory? Whether it's treating the pain addiction, or if you're pushing medications or vaccines or whatever, is there a corporate interest in keeping people doing it? Who benefits? And I think, unfortunately, now, as consumers, whether it's in medicine or anything else, you always need to be asking, who benefits from all this? What's the backstory? And I think certainly in pain management, that's been an issue. I think in a lot of other parts of medicine, that's an issue. I think that as I've gotten older and things have changed, especially in the last few years, you see more of a medicine as industry, and the physicians are not as big a part of what's going on. We're just basically practitioners and caregivers along the way, but a lot of the bigger decisions are made for other reasons at other levels. So that's one thing that I think has significantly changed.
Is that coming from like governmental changes, or is that coming from like administration, the healthcare facilities, or the corporations, or?
I think that there's always been, people try to control people. That's just natural. And there's forms of government where people want to control more and forms of government where people want to be controlled less. But there's government, and there's corporate, and there's institutional, and there's people that need power and control in all those areas at all sorts of different levels. And I think that in terms of government, a lot of times money talks in terms of what policies happen, and the larger companies have more money, so they have a larger voice. And I think that is something that I see. Maybe it's just my age and wisdom and maturity and being able to see things, but I think that has become significantly more of a factor in terms of how things occur. And I think that what happens on a corporate level then gets translated into a policy level and a governmental level. And so I think, and the administrators at the hospital have more power and authority than they did decades ago. So I think you're correct in all those areas. I think they're all a problem.
Did you have any interaction with, I guess it would be not drug reps, but like device reps? And because I know I heard stories for a while they had to kind of like put in limitations on kickbacks and things like that. Did you have any interaction with device reps in the orthopedic world?
I've had a lot of interaction with the device reps in the orthopedic world, and I have a couple of nephews that are device reps now, and so I get to see it from a completely different level than I saw it before. And it's again a double-edged sword. A lot of the device reps, they're quite knowledgeable, and they're knowledgeable about what they have, and sometimes that's a great resource, and sometimes it's an issue because they're pushing one device to the exclusion of others because that's who they represent. And so again, it's a buyer beware or the provider beware, and probably the patient should ask questions of what are the advantages of one device over another. And I think that it sounds like in places it got a little bit runaway at times with the device reps, pushing things and being an integral part of more than what they really are, which is, they've got knowledge about a device in a small area. So that can be a problem. And I've also known people that, I've got friends that were integral in making devices. And in orthopedics, it's a little different than some of the things because you're basically, if orthopedics is the carpentry of medicine, then a lot of the devices are, a lot of the prostheses are fixed, either with screws or nails, and a lot of the now the sutures are fixed with little screw-like anchors or such, and so that's a little different sort of technology, but it's basically engineering technology in that. And one friend I have that was very extensive in that, he basically pioneered it, and his sole reason was because he wanted to do something better, and that I think there's still an awful lot of people in medicine that they just want to take care of patients and do something better. And he fortunately had the very appropriate personality because of his who he was, his faith in that this is what he did, and when things didn't work, he changed them, and he was always looking for something better. So he did extremely well, but I have absolutely no. He deserved what he did because he changed the world, and so that is that's sort of my perspective from the orthopedic view. I know my father-in-law has a partner that, again, trying to solve a problem they were having in surgery, came up with a DC defibrillator, and so all the paddles you see in all the movies and all the aid cars and all that came out of a need, and that was just he had the expertise in terms of electronics was his hobby. This is the early 50s and early 60s, and then he did that. So I still think a lot of the times it's here's a need, let's fix it, and then once you have it, you've got to have somebody to represent it and sell it if you're going to do it. So there's certainly a place, and a lot of times people are very knowledgeable and helpful, but like anything, there can be a tendency to overdo and abuse if you don't watch it. So you as the provider have to be aware that that's a possibility, and I think that it's less subtle now and more obvious than it was in the past. But I think as a provider, you have to be aware, and I think as a consumer, you also need to be aware that there can be pros and cons, and so be smart, ask questions.
Mm-hmm. I recently saw a story. It wasn't orthopedic surgery, but it was just like a general surgeon, mm-hmm. and they had done a surgery remotely through robotics, and the patient was in a different country. So they have, I'm assuming it's very high-speed internet, and the surgeon was I think he was in the United States somewhere. I think it was in Orlando or out of Florida somewhere, mm-hmm. and the patient was in a country that didn't have the greatest healthcare or access to services, and he was able to do a remote robotic surgery, and I think it was like the first one that's been done, which is kind of amazing. It's a little weird, but it's amazing. Had you heard of that or any other where the future of surgery and orthopedics is headed?
Well, that's a concern, I think, or a question we all have, is how far can you go with robotics, and what could you do? And the first things that come to mind are, it's going to open up a whole lot of opportunities for patients that otherwise wouldn't exist. The other issue is, what happens if things go south and you have a problem with the robotics? Is there somebody there that's able to salvage things or correct things in that? So it's emerging technology, and there's going to be things that are great leaps forward, and there's going to be things that are going to be issues, and that'll sort itself out over the next few decades. But it's change that's going to be very beneficial in some places.
And I didn't have it. I don't know the details. Like, I'm sure that there was, there's someone in the room on the other end. There's right. nurses, and maybe there was even another physician in the room that didn't have the skill to do the surgery, but there could have been another physician in the room. But that's just wild that they can do that through the robotics and a strong internet connection, and it's and then it's like, whose protocols are they practicing under? And you're right, what if something goes wrong? Like, who's responsible? And it's I'm sure they had things in place, but
and I think we sometimes have a rather parochial view of who we are. My son and in practice, he'll probably join in Florida. One of the surgical assistants is a neurosurgeon from Columbia. Well, he couldn't jump through all the hoops to become accredited as a neurosurgeon or a spinal surgeon here, but he was able to practice in where he was in South America. Just the opportunities for him and the abilities to perform things weren't there, and he would rather be a surgical assistant here than having to. But there's very highly, a lot of foreign trained physicians are actually quite highly trained and able to do things. We just sometimes don't realize that there are, and a lot of innovations have come from foreign places too. So we really can't disparage places that can't quite do the same things, because a lot of times there are financial or other constraints that prevent that from happening, but it's not the person, it's the circumstance. Mm-hmm. So there's a lot of good people elsewhere, and so I would imagine that there was somebody that was pretty competent on the other end that could help as well.
Yeah. What do you think are some things that just in general the healthcare system has done extremely well or is doing right, and some things that need more attention or improvement? You see, maybe some areas for improvement, and how do we get to the place of improving them or making those changes?
I think people are curious. People are trying to advance things. I think what healthcare has done the best in is innovation that has allowed treatment and benefits that were not even conceived of in times past, that we're able to do and innovate. So I think that's probably the strength, especially in the United States, has been the ability to innovate and bring those innovations into practice. So I think those are that's the greatest strength. I think again, just thinking about it, I used the example of a femur fracture in the past. In the Civil War, a femur fracture carried a 90% mortality. In World War I, that had dropped to 15% because of the traction and that method of treatment that an English physician came up with at the start of the 20th century because of all the guys falling off bridges they were building. Mm-hmm. And so that was a huge, from 90% to 15%, that's a huge change. And now with the IM nails, which can be done in a 2 or 3 day hospital stay at times, and a very, very low mortality and a very low non-union rate. That's a huge quantum change, and we've seen that in medications, and we've seen it in cardiac procedures and ENT procedures throughout medicine. That's been the strength. One of the emerging, I think, more obvious issues with medicine is the monetary or corporate control of medicine. They talk about big pharma. Well, there's a lot of money and therefore political power that goes in, and some of the things that are happening are probably not appropriate. I think that the interaction of business and government has not been good. Take, for example, well, the recent vaccines for COVID and some of the other vaccines, now we're hearing that there were miscarriage rates of up to 88% in the early trials, which got buried. And some of the trials in terms of autism, they fudged the numbers by excluding people that were older, so that the autism rates weren't as high because there hadn't been as much time to see the autism development. So I think that corporate interests are typically financial, and if those are not monitored, and I don't think that we've monitored, some states have done better. I think Florida's done better than a lot of the other states, certainly Washington, in terms of allowing two sides and seeing where the facts lie. I think if you're not willing to do that, there's going to be abuses because of money and power, and the government constraining things that they shouldn't be. And I see that as a huge issue in medicine and in healthcare policy going forward. I think that there's certainly a lot of voices now that are looking at alternatives to only pharmacologic things. I think that there's a new interest in what people are saying, holistic or natural medicine, the whole idea of naturopaths and holistic practitioners, and that they're looking for something other than just a pharmaceutical answer to things. And it's back to realizing that if what you have is a nail, you're always looking for a hammer. You need to be cognizant that there may be other things that you can use, and I think that that's something that I think consumers need to be aware of, providers need to be aware of, certainly government needs to be aware of, and you have to realize that back to who benefits. Well, corporations benefit if they can make money, and that's really what they're there for. If the shareholders or whatever, so you've got to realize that other people other institutions need to have the ability to appropriately look at both sides of all the issues and see what's best. And I think that we're beginning to do that. Some places are farther ahead than others, certainly in our country, but I think that provides opportunity too, because I think that there's a lot of ways of doing things that if we are smart and curious, we'll have a better outcome than just going down one path or allowing one set of people to define how things are done.
Mm-hmm. Do you have any interesting cases or stories that maybe one or two that just stick out that you'll never forget about? Anything that's just, I don't know, unusual or something that's just memorable, whether it's your first case that you did or just, I don't know, anything like that?
Well, you look back at patients, and I think one of my favorite patients was a kid with Down syndrome, and unfortunately you don't see the number of kids with Downs anymore. They don't exist, they don't make it. But this was probably 20, 30 years ago, and he was a kid that had terrible knee pain. Nobody could figure it out, and everything that looked fine, and he just had disabling knee pain. He'd been pretty productive working and all that. He And when I looked in his knee, it looked perfect, but he said it was painful. So for some reason, I was brave enough just to finally just took his kneecap out because of the knee pain he was having. And that totally transformed him. He was all of a sudden back to being productive. And
you took his kneecap out?
Yeah. Yeah. Paddlectomy is something that you'll do sometimes for people with severe arthritis of their kneecap. It's just you trim it out. And there's real advantages to doing it. There's some very significant disadvantages because you're changing the whole extensor mechanism and the tracking and the mechanical advantage, and you may have some weakness in that. So it wasn't certainly anything I wanted to do lightly. No one else had been willing to do it, and somehow he convinced me that, okay, this is probably the best chance he's got, and it worked great. And he was all of a sudden back to doing his fishing and rowing the boat, and back to doing some work in that he couldn't do. And when the other knee started acting up the same way, I was much quicker to pull the trigger that time with the same effect. And what I realized was that this kid was what we all would like to have, completely normal. My job was, if he had a complaint, it was real. My job was to find it and fix it. And there were no filters. And I remember one of the surgeries that he did. I did several surgeries for other things too, but on him. But he was getting his IV put in down in the holding area in the surgery department, and he was just screaming. You could hear him throughout the entire operating suite. But his arm was just rock still. He was letting you do that. He wasn't moving, but he was screaming bloody murder. And I'm thinking, this is what we were all like on the inside. We're all screaming bloody murder, but we have the constraints to, socially to say, okay, I've got to gut it out and be quiet and look brave for everybody. But in the inside, I'm still kind of, this is who I am. And he just let it be, and that was the strength of things. He just, what he was totally real. And that whole class of patients, the folks with Downs, they had great insights. They were they were totally honest with you. What you got was what you got. Great sense of humor. I remember one gal I had whose mom was trying to help her out at the work, and she said, well, I had to tell them that they gotta be a little easy on her because she's older and it's kind of hard for her. Just the genuineness of those people, that was something that's always stuck with me.
The
daughter had Downs, and mom was helping out doing some of the work, and you got it. She's older. You just have to realize she can't do. It's just the genuineness is there, and the caring. So that was something that that class of people were a lot of fun. But it was that was memorable. But doing some of the innovations has always been fun. Doing the first time nail at Mayo was fun, and there's a method of emergency airway access that's quicker than the tracheostomies that people always used to do. And my father-in-law, this kid, showed me. He showed me an article. Because like I said, they were still doing them for cardiac surgery back in the mid-'70s, and a group in Denver decided to do this other procedure, which had been bad-mouthed before, and they had a series of like 400 patients. So it sounded to me like it made good sense. I brought it up when I was an intern, and at one of the early meetings of the surgery department, and I had the chairman of ENT create a new elementary orifice for me in front of the entire house staff, and but I just kind of filed it away. And a year later, I was first-year ortho resident and taping an ankle in the ER, and somebody came in that had obstruction. They couldn't get the forceps to get the meat out, and know what to do. So I decided we should do this, and it worked. The guy the meat popped out because of his negative pressure he from sucking in. Once that equalized, the meat popped out, and it worked well. And now, if you take an advanced trauma life support course, that's the preferred way of creating an airway. Mm-hmm. So, it's kind of interesting to sometimes be on the front end of things.
Yeah.
I'm sure there's things I've been on the front end of I shouldn't have as well. But, yeah, you need to keep your mind open to innovation and what you do. And sometimes, what is thought to be terrible, and this isn't, many things in life is actually later what the gold standard is. Mm-hmm. So, be open. Mm-hmm. Be aware.
Well, Dr. Degan, thanks for taking the time to talk to me and share your stories and your knowledge that you've gained over the past almost 45 years of being in practice. I appreciate it.
Thank you.